Hello everyone and welcome to this evening's event, and thank you all for joining us for the third instalment in our 6-part GP webinar series for 2022. My name is Louise O'Leary. I work as Advocacy Manager in St. Patrick's Mental Health Services, and I'll just be sharing some housekeeping information before introducing this evening's speaker. Tonight's hour-long webinar explores how GPs can treat and support their patients living with bipolar affective disorder. Our speaker this evening is Sean Lonergan, a cognitive behavioural therapist on the Bipolar Disorder Programme here at St. Patrick's. Sean will discuss ways to increase recognition of patients presenting with symptoms of bipolar affective disorder in primary care, how to differentiate bipolar affective disorder from unipolar depression, types of bipolar affective disorder diagnoses, risk factors and stressors for people living with bipolar affective disorder, supporting patients at different stages, and when to refer a patient to specialist care. Following the presentation, we will have time for a short question and answer with Sean. You can submit questions throughout the webinar if you like, using the Q&A function at the bottom of your screens, and then we'll try to get through as many as possible in our Q&A session. ICGP CPD certificates will automatically be sent within the next 4 weeks to any GP who is registered and is attending live this evening. So without further ado, we shall get started. Let me introduce you to tonight's speaker, Sean Lonergan, and hand over to him.
Hello, good evening, and thank you for joining us. So my name is Sean Lonergan. Thank you very much for the kind introduction. I'm just going to bring up the slides for today's webinar. So today, we're going to discuss GP management of bipolar affective disorder. And we're thinking about when to refer for specialist care, working in primary care. So we're going to look at a number of different factors, and there's some learning aims that we're hoping we can cover in the webinar today to increase the recognition and awareness of how patients may present with symptoms of bipolar affective disorder in primary care, to consider how to differentiate bipolar affective disorder from unipolar depression, to differentially diagnose types of bipolar affective disorder, to consider risk factors and stressors that can leave patients more vulnerable to mood instability, to understand how patients' vulnerability to mood instability can become a bipolar episode, and supporting patients when they are well, becoming unwell, and when a severe mood episode occurs. We'll also be looking at guidance on deciding when to refer for specialist care for adults, for adolescents over 14 years old, and for children and adolescents below 14 years old, and guidance regarding treatment for patients through development of biopsychosocial protective factors against relapse and helping foster maintenance of recovery following an episode of mood instability. The overall aim is to enhance your awareness of useful resources, including support groups for patients with bipolar and support groups for patients' families and friends who are living with bipolar. So we're thinking about caring for the caregiver, along with some, hopefully, other useful resources that you might have. So when we think about bipolar, GPs are central in terms of the care and provision of treatment. So for the majority of people living with bipolar, their GP will be the primary treating clinician that they have. The best mental health care comes from a partnership between professional treatment providers, if they're involved, the person living with bipolar, and their close supporters. And as a GP, your informed care and support can make all the difference, especially so as you may well be treating some of their family members and friends as well. So you can help by learning about bipolar affective disorder, effective models of treatment and care, and how to support their recovery, and encourage and support collaboration and treatment concordance amongst each member of the support system. What we know is bipolar affective disorder can affect not only the life of the person with the illness, but also their close family, partners, and friends. And significant people in a person's life are often a source of support with the illness. However, both patients with a diagnosis of bipolar, their family, partners, and friends may be faced with bipolar illness without much information on ways to deal with it and support in managing its impact on their life. And it's important to know how to diagnose, treat, and collaboratively support both your patients and their supporters and caregivers in liaising with other services and treatment providers as needed. So I suppose a good first step towards that is your attendance at the webinar here this evening. So I'm hoping that some of these learnings at least will be achieved. So first I'll start with clinical descriptions and epidemiology of mood disorders as a whole. So when you think about mood disorders, there are two broad types. The first involves only depressive symptoms, and the second involves depressive symptoms with potentially manic symptoms, and that would be called bipolar disorders. Within the Diagnostic Statistic Manual 5, depressive disorders that are recognized include major depressive disorder, persistent depressive disorder, premenstrual dysphoric disorder, and disruptive mood dysregulation disorder. Within bipolar disorders, we have bipolar 1 disorder, bipolar 2 disorder, and cyclothymia. There are other bipolar disorders on the spectrum that aren't necessarily recognized in the DSM-5, which I will touch upon, but not necessarily go into detail on this evening. So this is a bit of an outline for each of those disorders. So we're going to be looking at bipolar 1, which typically consists of at least one manic episode within the lifetime of the individual. Bipolar 2, with at least one lifetime hypomanic episode and one major depressive episode. And cyclothymia, which is a recurrent mood change from high to low for at least 2 years without hypomanic or depressive episodes. So we're going to look at that in a bit more detail as we go along. When you think about bipolar affective disorder, it means it's a cyclical mood disorder. So the person goes through cycles or episodes of mood disturbance, and it's potentially lifelong and disabling condition. Not necessarily, but most likely. Bipolar disorder refers to a spectrum of disorders that involve unusual changes in mood, activity, and energy. And these changes in mood or behavior are different than the typical highs and lows that adults generally experience. In bipolar disorder, the highs are called manic episodes or cycles, or in less severe cases, hypomanic episodes. And the lows are episodes or cycles of degrees of depressed mood. There are 3 forms that we're going to touch on today, as I mentioned. So bipolar 1, bipolar 2, and cyclothymia. Some degree of manic symptoms are a defining feature of each. So you cannot be diagnosed with a bipolar disorder unless you've had some form of hypomania or mania. Each of these are differentiated by their severity and duration of the mania experience, and usually involve episodes of depression alternating with mania, but not necessarily. So for instance, with bipolar 1, there are some people who have predominantly manic experience without necessarily experiencing depressive episodes following those. Depressive episodes are required for bipolar 2, but not necessarily for bipolar 1. All you need is a manic episode for that diagnosis. So when we're thinking about mania and hypomania, we're really thinking to a large degree on the duration, but also the severity and number of symptoms. So for a manic episode, this would be represented by a state of intense elation or irritability. The symptoms typically last for at least 1 week or require hospitalization and or include psychosis. And symptoms cause significant distress and or functional impairment. For a hypomanic episode, the duration needed for a diagnosis is less, so symptoms of at least 4 days. So we typically think about hypomanic experience as reduced in intensity in terms of the symptoms, and also reduction in duration of the symptoms. Any and all symptoms in mania can be presented within a hypomanic episode except for psychotic symptoms. So there are clear changes in functioning that are observable to others, but impairment is not necessarily as marked, and there are no psychotic symptoms for hypomania. These are common symptoms a person may experience if they are experiencing a manic episode. Increased energy, activity, and restlessness, possibly agitation, physically excessively high, overly good euphoric mood, extreme irritability, racing thoughts and talking very fast, jumping from one idea to another, being quite distractible, difficulty concentrating, little sleep needed, if not sleeping at all, while being full of energy for prolonged periods, days at a time potentially. Unrealistic beliefs in one's abilities and powers, so quite grandiose beliefs about the self and a person's abilities, often feeling quite inspired potentially along with that. What others may deem as poor judgment, potential for impulsive behavior such as spending sprees. I suppose one of the things just to keep in mind is it's a lasting period of behavior that's different from that person's usual behavior. So in that sense, knowing your patient is very helpful in being able to differentiate their healthy behavior patterns from perhaps a manic or hypomanic experience. Increased sexual drive and libido, and potentially risky sexual behaviors, potential for abuse of substances and sleeping medications, possibly appearing to others as more provocative, intrusive, or aggressive, and likely denial that anything is wrong. So the criteria for manic or hypomanic episodes is that at least 3 of the following symptoms are noticeably changed from the person's baseline, and 4 if mood is irritable. That's increase in goal-directed activity or psychomotor agitation, unusual talkativeness, including rapid speech, flight of ideas or subjective impression that thoughts are racing, decreased need for sleep, increased self-esteem, special talents, powers, abilities, plans, distractibility and attention is easily diverted, and excessive involvement in activities that are likely to have undesirable consequences. When making a diagnosis of bipolar disorder, something to keep in mind is that it takes an average of 8 to 9 years to get a correct diagnosis of bipolar disorder. And there is a misdiagnosis on average 3.5 times of unipolar depression of what turns out later to be diagnosed as a bipolar disorder. So there are different, perhaps contributing factors to that, but it does suggest that there might be a predisposition for diagnosticians to have a bias to understand a person presenting with a mood problem as singular unipolar depression, rather than perhaps considering bipolar condition that may be present, or being maybe hesitant or unwilling to make that diagnosis. We're going to look at some other reasons why that could be, that a person will often present with a range of other factors and concerns other than mania or hypomania that might suggest a bipolar illness. That makes it also much more difficult for diagnosis, but it's something to keep in mind a little bit. So a diagnosis of bipolar disorder is dependent upon specific criteria, but you may well be using different criteria depending on which classification system you're using. If you're using the ICD or ICD-10 or the more recent ICD-11, it requires at least 2 discrete mood episodes, at least one of which must be hypomania or mania, and 1 depressive episode lasting at least 2 weeks. If you're following the DSM-5, it requires at least a single episode of mania without an episode of depression, or a single episode of hypomania with 1 major depressive episode. So I'm not too sure if having different criteria particularly helps with the diagnostician being able to make an accurate diagnosis. The estimated prevalence of bipolar affective disorder amongst the Western population seems to vary depending on, I suppose, what statistics you're looking at. Aware suggests that approximately 45,000 people, or 1 in 100 people approximately in Ireland, have bipolar illness. In the UK, statistically, it seems to be indicated that it's about 1 in 50 people and approximately 2.8% in the US. So that would suggest that there could be quite a large range of difference in how bipolar illness is being presented, diagnosed, or the percentage of people within a population that might be represented as having a bipolar illness, which is something that is quite interesting as well. But then you could break that down in terms of what particular mood disorder you're talking about within that, or type of bipolar disorder. In terms of prevalence rates, within the US, 1% or 0.6% worldwide seem to be understood to have bipolar 1. Between 0.4 and 2%, which is quite a large range, are thought to have bipolar 2. And approximately 4% are thought to potentially have cyclothymia. On average, the onset is typically around the 20s, but also later in early middle age, there's also a peak of onset or diagnosis for bipolar as well. There are no major gender differences in rates of bipolar, and women tend to experience slightly more depressive episodes, but there's not a significant gender difference typically. Bipolar has to be understood as a severe mental illness. For those who have been hospitalized with a bipolar illness, a third remain unemployed a year after hospitalization. So there can be continuing and significant functional impairment, and suicide rates are high, which we're going to look at in more detail. Common comorbid conditions. When we think about this, comorbidity is very much the rule rather than the exception. Approximately 100% of patients with bipolar 1 are thought to have another psychiatric disorder within their lifetimes. And up to 95% are reporting 3 or more. That's within the US in a particular study there. Anxiety disorders tend to be very common alongside bipolar 1 disorder. You have substance use disorders, conduct disorders, and antisocial behaviors. Common medical comorbidities include migraine, thyroid disease, being overweight and obese, diabetes, cardiovascular diseases and hypertension, chronic obstructive pulmonary disease and asthma, human immunodeficiency virus, and hepatitis C. In terms of the course and prognosis, for most people with bipolar disorder is chronic and recurrent. There is a large variation between individuals and the number of episodes experienced. Episodes of mania and depression tend to cluster together, so typically people may experience a number of illness episodes together, followed by a more quiescent period, and then another cluster of episodes. This pattern with hypomanic and depressive episodes is especially common in bipolar 2 disorder. And the risk of recurrence in 12 months after a mood episode is particularly high, 50% within 1 year, 75% at 4 years, and after that, approximately 10% per year in addition, compared with other psychiatric disorders. When we think about the etiology of mood disorders, when we think about what factors contribute to the onset of mood, we're mindful of both nature and nurture, so neurobiological factors and psychosocial factors. We usually think of this as a complex mix of different factors. So what can contribute to a person's vulnerability to instability of mood within bipolar? There's a very strong evidence base that is highly heritable. So a significant genetic predisposition can have a significant input. A person's temperament, their approach to life, their view of themselves, their coping strategies for managing stress, their values, goals, drive, and expectations, the nature of their social relationships, environmental factors such as light and dark, change in seasons, noise levels, time zones, life events, drugs and alcohol use, biological factors. So any disturbance to the body clock and the sleep-wake cycle can have a significant impact in increasing a person's vulnerability and likelihood of mood instability. Changes in hormones, messaging system, neurotransmitters in the brain. Each and every one of these, amongst other factors, can have a direct input into how vulnerable or unstable a person with bipolar's mood may be. When we look at neurobiological factors, there's a very high heritability estimate. So major depressive disorder is thought to have a 37% approximately, or quite moderate but significant heritability. And for bipolar disorder, that's 93%. So if a person has a close relative with bipolar disorder, the vulnerability of them potentially having mood disorder, in particular bipolar disorder, is significantly higher. Looking at social factors, significant life events, such as stressful life events in the year prior to depression onset, that could be romantic breakup, loss of job, death of loved one, can all add to a person's vulnerability or likelihood of having a bipolar mood episode. General interpersonal difficulties with high levels of expressed emotion, which we'll touch on towards the end of today's webinar, by a family member, predict relapse. And marital conflicts can also be a predictor for depression. General lack of support may be one reason that stressor triggers depression also. When you look at triggers of depressive episodes in bipolar disorder, they appear similar to the triggers of major depressive episodes. So typically negative life events, how neurotic a person may be, negative cognitions, the level of expressed emotion in the family environment, and a lack of social support. Predictors of mania would be the level of reward sensitivity of a person and how much sleep disruption and sensitivity to sleep disruption the person may have. So when we're looking at differential diagnosis of bipolar affective disorder and subtypes, so we were looking at what bipolar is a little bit earlier, and it's really important to differentiate mania, hypomania, and depressive symptoms from the general ordinary mood changes people experience in response to ups and downs in life, where they have a particularly good day or maybe not so good a day. And it involves mood episodes where the person's thinking, feeling, behavior changes noticeably and for a considerable duration of time and affects their daily functioning. So it has to be a combination of all of those factors for that to be recognized and thought about. So when you think about bipolar on a mood spectrum, so far from being a discrete diagnostic entity where it was just called manic depression, typically represented as bipolar 1 in the past, there's an increasing recognition of a spectrum of bipolar disorders that ranges from marked and severe mood disturbance into moderate mood variations that become more difficult to distinguish from normal mood fluctuation. So at the high end, we have bipolar 1 with potential for psychotic features or symptoms, bipolar 2, cyclothymia, rapid cycling, mixed mood states or dysphoric mania, where you have a combination of hypomania and depressive symptoms at the same time. And in the middle, we have our healthy mood states. And then we have degrees or severity of depression, so mild, moderate, severe, with or without psychotic symptoms at the end. So here's a bit of a representation of the 3 bipolar diagnoses that we were mentioning at the beginning. So at bipolar 1, manic episodes require or can essentially be very, very severe in terms of high mood and very, very severe in terms of low mood. So it's the absolute extremes of the mood spectrum that's represented. So the green line in the graph here represents bipolar 1, and the blue line is okay mood. So we are very far above and potentially very far below. Not everybody will have severe depressive experiences. Some people will only have manic experiences, but the tendency is to have a bit of both. When it comes to bipolar 2, we're having more mild to moderate highs of hypomania, but still with the potential for severe depressive episodes. So we're going about halfway up here. On the graph, still well above okay mood or a very good day. But the general tendency is the person will experience depression primarily and identify with their experience of depression. But because a person's hypomania may be a bit more mild to moderate, it can be potentially explained away in other ways and may be less accepted by the patient. Even if retrospectively, there might be many different incidences where that occurred. Cyclothymia is the milder version of both ends. So it's more mild to moderate high and mild to moderate low, which is represented by the orange line here. It's still above a good day for longer, and it's still below a bad day for longer and more intensely. However, it's not causing as much functional impairment or disruption. And typically for this diagnosis, A person will have to be experienced more of these mild to moderate, on the mild end of the moderate, hypomanic and depressive episodes for at least 2 years for that diagnosis to be made. So here's another illustration. So it's just trying to differentiate the healthy mood states in the middle. So we have balanced mood or okay mood, and it allows for good days and blue days, perhaps even a few good days and a few blue days within that healthy mood spectrum. So how do we start to differentiate the mild to moderate bipolar illness from more mild to moderate general fluctuations in good or bad mood? And that's something that has to be really considered, and certainly look at the diagnostic criteria very carefully and be looking at histories. And we're going to look at some tools that might help with that as well. When we think about mania, we have loss of insight typically. Full insight is quite often lost. So the person has really no awareness of any problem whatsoever. They probably feel extra right. Their behavior to them will not be perceived likely as abnormal or problematic. And they will typically not consider him or herself to be in need of treatment. Clinical interventions, if you were to try to intervene, may be seen as attempts to undermine the person's esteem and power, and could provoke or worsen irritability, even in those who are predominantly euphoric. So they may well not exactly come to you in the first place for help or participate in the treatment process that you might be trying to support them with. When it comes to depression, although mania or hypomania are the defining characteristics for a diagnosis of bipolar disorder, throughout the course of the illness, depressive symptoms are by far the more common experience rather than manic symptoms. Major depressive episodes in bipolar disorder present as very similar to those experienced in unipolar major depression. You won't likely be able to determine if a person has bipolar depression or unipolar depression just by their reported experience of depression alone, as that experience of depression will really have the same range of symptoms in either form. So when we think about depression, we have a range of symptoms such as loss of enjoyment, cognitive impairment, psychomotor changes, typically a slowing down, although sometimes racing thoughts, negative thoughts as well, social withdrawal, suicidal thoughts, inability to concentrate, changes in sleep, changes in appetite. So that can go in both extremes. So difficulty sleeping, getting to sleep, staying asleep, waking early, sleeping too much, change in appetite from undereating to overeating, gaining weight to losing weight. So it can really be a mixed bag. Obsessive rumination, typically of a very self-critical, self-loathing form. General aches and pains, low energy, tearfulness, loss of interest and motivation, irritability, feelings of guilt and worthlessness, anxiety, and pervasive low mood. Sometimes severe episodes of bipolar mania or severe depression can include symptoms of psychosis. Common psychotic symptoms include hallucinations where the person perceives either through hearing, seeing, or physically feeling some other sense of a presence of things not actually there, and delusions, which are false, strongly held beliefs not influenced by logical reasoning or evidence to the contrary. Psychosis is an especially prevalent phenotype in bipolar disorder, with greater than half of all individuals diagnosed with bipolar disorder experiencing some form of psychotic mood episodes in their lifetime. When it comes to hallucinations and delusions, they're very much influenced by the person's mood. So if a person is experiencing a manic episode, they're more likely to have beliefs of delusions of grandeur, feeling extra special and powerful. If they're having a depressive mood episode with psychotic features, they may well be having delusions of guilt or worthlessness, such as they ruined someone's life, or they are ruined in terms of being penniless, or that they committed some terrible crime that they have done nothing of the sort of. When you think about the presentation of a patient with bipolar in primary care, there are some things to consider. So patients with bipolar disorder presenting in primary care with a wide range of symptoms, including depression, anxiety, mood swings, difficulty sleeping, irritability, fatigue, and inability to focus and concentrate. that would be a quite typical presentation for GPs. How can you differentiate those from perhaps bipolar illness? They may also exhibit physical consequences of their illness, such as alcohol-related problems or sexually transmitted or drug-related infections. Patient social histories often uncover other sequelae of the illness, including relationship and marital problems, financial trouble, erratic occupational histories, and legal issues. Here's a representation of common presentations of bipolar patients in primary care. So relationship difficulties are most common, and you've work, school-related difficulties, interpersonal conflicts, financial difficulties, marital difficulties, physical health difficulties, and alcohol substance misuse difficulties. So bipolar disorder can commence in childhood, but onset is most common in adolescence or early adulthood, so between 15 and 19 years old, and a second smaller peak of onset of bipolar 1 and 2 disorder in later life between 45 and 54 years old. Women with bipolar disorder are at risk of a significant mood disturbance both during pregnancy and in the postpartum period, most commonly in the first 4 weeks. Most will have a depressive episode, a significant proportion will have highs, and 10% will have mixed highs and lows. Women and men develop bipolar 1 disorder at equal rates, while the rate of bipolar 2 is somewhat higher in females. Undiagnosed and misdiagnosed bipolar affective disorder. Why is this important? A delay in diagnosis can have many consequences. So a large retrospective study, as we mentioned earlier, here it says 8 years, so between 8 and 9 years for bipolar typically to be diagnosed accurately. Measurement of the incidence of bipolar is fraught with difficulty because subclinical symptoms of bipolar disorder are common. There can be substantial delays of many years duration before a patient presents to services, and presentation to services is often initially with depression, ill-defined psychotic symptoms, or an impulse control problem. So the nature of the bipolar disorder is often only diagnosed some years after the initial presentation. It's highly unlikely that a patient will walk in complaining of mania or hypomania. They will likely be perceiving that as the best version of themselves. When it comes to cost of delay in diagnosis and misdiagnosis, without appropriate treatment, the natural course of bipolar disorder tends to worsen. Over time, a person may suffer more frequent, more rapid cycling, so more cycles happening more often, and more severe manic and depressive episodes than those experienced when the illness first appeared. So that's the very unfortunate, tragic part. If it takes 8 to 9 years for diagnosis, the person may well be getting diagnosed because their illness is far more severe and more difficult to treat. But in most cases, effective treatment can help reduce the frequency and severity of episodes. Bipolar disorder is not only a disorder of mood and behavioral alterations, it's also perhaps one that can impact cognitive functioning and impairment. In 146 euthymic outpatients with unipolar and bipolar disorders, a higher number of prior mood episodes was associated with increased cognitive impairment. So early intervention is by far the better outcome. Interviewing the patient may well fail to identify any overt features of an elevated mood. If you're just hoping to observe it in your 10 minutes or 15 minutes or brief contact. In such situations, the individual may be capable of containing themselves for limited periods of time. Therefore, collateral information from a partner, relative, or close friend is crucial if you have any suspicions that bipolar mood may be a factor. Where a patient presents with hypomania and mania symptoms and has a previous episode of treatment for depression, the possibility of bipolar affective disorder should be considered. So how do you screen for, detect, and identify hypomania in particular? Mania would likely stand out quite clearly, but hypomania. GPs are positioned to play a crucial role in the management of mania and its less severe form, hypomania. In this regard, there are two aspects of an elevated mood worth considering. The early identification of an evolving mania right now, and detecting episodes of hypomania historically that might have been overlooked. And that's more likely what you will find yourself catching. if you start looking for it. So when we look at screening for hypomania, a number of screening tests are being devised to assist in the recognition of a bipolar II mood disorder. And a good example of this is called the Mood Disorder Questionnaire. There's a reference here, and this is a screening tool with good sensitivity and very good specificity in an outpatient setting. There's also a single question to screen for hypomanic mood if you have any suspicion that that may be a possibility. Have you ever in your life experienced an episode lasting 3 or more days when you needed much less sleep than normal, yet had more energy and activities than usual, felt wound up or on top of the world, and had racing thoughts? If the answer is yes, consider that they may have experienced a hypomanic mood episode and that further exploration is worthwhile, and perhaps using the MDQ could be quite useful in exploring a bit further. It's a checklist essentially of potential symptoms, and these would indicate one way or the other if there is a greater or lesser likelihood that bipolar illness might be happening for that individual. When to refer to specialist care. So I suppose this is reasonably common sense in some ways. Refer urgently a patient with bipolar disorder if there's an acute exacerbation of symptoms, particularly mania or severe depression, or there's an increase in the degree and or change in the nature of risk to themselves or other people. I guess a little bit more thought-provoking when we start looking at some of the other suggested considerations. So if bipolar disorder is managed solely in primary care, you can refer or re-refer to secondary care if any one of the following applies. There is a poor or partial response to treatment. The person's functioning declines significantly. Treatment adherence is poor. The person develops intolerable or medically important side effects from medication. Comorbid alcohol or drug misuse is suspected. The person is considering stopping any medication after a period of relatively stable mood. A woman with bipolar disorder is pregnant or planning a pregnancy. Again, unless you feel comfortable and confident that these concerns can be managed, but certainly it's a consideration at that point for potential referral on for specialist care or treatment. When adults present in primary care with depression, what can be helpful is to ask your patients about possible previous periods of overactivity or disinhibited behavior, and to try and maybe get in the habit of doing this. So without necessarily having to wait for calls to ask, to make this perhaps one of the things you typically ask when a person presents with depression, even if they've had depression for some period of time, and that's what you've been treating them for, to maybe check in if this may have been the case. If the overactivity or disinhibited behavior lasted for 4 days or more, you might want to consider referral for a specialist mental health assessment. And refer patients urgently for a specialist mental health assessment if mania or severe depression is suspected, or they are a danger to themselves or others. That's really a sure thing. In terms of recognition and referral of bipolar disorder in children or young people, NICE guidelines have some very specific differences. One is the MDQ is not recommended, so do not use questionnaires in primary care to identify bipolar disorder in children or young people. That's only for adults. If bipolar disorder is suspected in primary care in children or young people aged under 14 years, refer them to a Child and Adolescent Mental Health Service, CAM service. If bipolar disorder is suspected in primary care in young people aged 14 years or over, refer them to a specialist early intervention and psychosis service or a CAMS team, depending on what's available to you, with expertise in the assessment and management of bipolar disorder in line with the recommendations in this guideline. So in terms of risk of suicide amongst people with bipolar, there is some evidence that people with bipolar disorder do not receive help, promotion, or treatment as readily as people in the general population. Compared with the general population, the standardized mortality rate for patients diagnosed with bipolar disorder for suicide is much higher. Approximately 17% of people with bipolar 1 disorder and 24% of people with bipolar 2 disorder attempt suicide during the course of their illness, which is a remarkably high proportion. Annually, around 0.4% of people with bipolar disorder will die by suicide, which is vastly greater than the international population average. And the greatest risk of suicide attempt is indicated to occur during depressed or mixed episodes rather than manic or hypomanic episodes. So the treatment of chronic low-grade depressive symptoms associated with bipolar disorder may seem less urgent to address and important to clinicians and carers than the management of more dramatic, alarming, and challenging symptoms of mania with more extreme behavioral change. However, the subsyndromal depressive symptoms may be more distressing in the long term and may well carry a greater risk of suicide, partly due to the ongoing suffering and functional impairment a person may experience. So the treatment of these chronic depressive symptoms is therefore of major importance, but it's also a substantial treatment challenge. There might be an increase in impulsive risk-taking behavior in mania with a high potential for negative consequences. However, there is no excess risk of bipolar disorder with violent crime, except when it's comorbid with substance use disorders. There may be increase of impulsive behavior problems such as shoplifting, overspending, motor accidents, perhaps, or risky sexual practices. In terms of treatments for bipolar affective disorder, before we think about that, it's worth thinking what you believe. Can bipolar be cured? Do you try to take a treatment or a cure approach? And how do you address perhaps a patient's belief regarding a desire to be cured if perhaps a treatment is more the likely course? So there's no clear answer, but what is understood is there's certainly no one cure. Some people who are lucky will have lifelong remission and never experience another episode of mania or depression again. However, this is very rare. Usually bipolar mood disturbance is recurring. There typically will be periods when the individual remains well for a period, only to find symptoms reappear later. Much can be done to reduce the severity or duration of an episode, or even the number of episodes experienced. And the best treatment is usually a combination of medication, psychotherapy, and self-management alongside support from loved ones. Bipolar disorder can be managed with a combination of medication, psychological therapy, family, and peer support. And typical recommendations, a combination of medication and psychosocial treatments, advocating a collaborative approach to the management of bipolar disorder, and self-management. So self-management is built on the principle that if you're able to recognize the early triggers and warning signs of an impending episode and implement appropriate coping mechanisms, then greater control can be achieved over mood shifts and episodes. Self-management programs aim to help the person living with bipolar to take an active part in their own recovery so they're not controlled by their illness. Think about who's involved in offering treatment for bipolar disorder. For the majority of people living with bipolar, as we said at the beginning, you, the GP, will be the primary treating clinician. However, many different treatment providers can be involved as needed. So it could also include a psychiatrist, pharmacist, psychiatric nurse, social worker, occupational therapist, for those who are working, an occupational health worker, perhaps a psychologist, individual couple and or family psychotherapist. It could include housing support. There's a wide range of multidisciplinary professionals that could be supporting a person. Collaborative care is a way for individuals and their family or friends to work together with their clinician to get the best results from treatment. It encourages the individual to assume the largest share of responsibility for making treatment work and fosters treatment concordance, which is referring to the extent which the individual, their clinician, and support system are in agreement about the care plan. If there's disagreement between the individual, their clinician, and support system, then treatment concordance is likely to be less effective, and the risk of relapse and poor outcome is greater. So elements of collaborative care include becoming knowledgeable about bipolar disorder and its treatment, developing a system of supportive individuals to participate in a care plan, and learning how to communicate efficiently with clinicians, therapists, and other members of the support team. So it's important to consider how you communicate and agree upon the goals of medication treatment with the patient and their supporters. Medicines aim to provide and treat episodes of mania, hypomania, and depression to improve symptoms, optimize drug dosage for maximum therapeutic benefit, to minimize side effects, and to optimize adherence. And they're the core, I suppose, areas to stress with regard to a patient with bipolar. And in terms of relapse prevention, here are just some suggestions. Problem solving at present to prevent relapse through managing expectations, distress, and fear of medication side effects. The costs of discontinuation and not taking as prescribed are important. So it does help to take the time to set out shared realistic aims of success with any treatment and to check the patient's aims, expectations of treatment. To check the fears and experiences that the patient may have regarding medications such as antidepressants. So how long do they take to work? Information about the titration or dose, discontinuation reactions and side effects. If these occur without them knowing about them, expecting them, or knowing what to do about them, that can certainly impact the likelihood of the person's adherence to taking that medication, and even trust in the prescriber. It helps to discuss specific fears and worries. So the common worries that people mention are worries about addiction, consequences for pregnancy, breastfeeding, and family planning. Maybe to discuss likely and possible problems with medications the patient can experience, and what's very helpful and important, to review regularly and address side effects over time. To try and anticipate that the patient may independently discontinue their medication or not take as prescribed from the beginning, and provide guidance from the outset regarding the consequences of that, and that would be a significant factor that could lead to relapse. In terms of understanding medication treatment, it's helpful to provide guidance to where the patient can find further information, so they feel empowered and they kind of know what to expect more as well. So medication most often works, but not immediately. Medication usually works best in combination with other treatments. There are many different antidepressants, mood stabilizers, and antipsychotic medications available to instill hope, which is very important for anyone's resilience. Finding the right medication combination and dosage for each person can take time, and treatment is a partnership with the medical team. So there would be the key points to suggest you stress. And really emphasizing that stopping too early or too quickly is a common cause for relapse, and to share perhaps reliable sites of information or sources of information for learning more about medications.
Sean, sorry to interrupt. I just wanted to let you know we have 10 minutes left.
Okay, no pressure. Thank you. Good for time check then. So psychological therapy treatments include cognitive behavioral therapy or other forms of psychotherapy, such as interpersonal and social rhythm therapy and family-focused treatment. When we look at CBT or cognitive behavior therapy, for instance, the approach is to a treatment of bipolar disorder that aims to enhance compliance with recommended treatment, such as consistent prescribed medication use, improve non-pharmacological coping skills, and to support individuals to manage psychosocial stressors. The intention is to understand and learn from the impact of past episodes, encourage monitoring of mood, and developing specific strategies for dealing with mood-related cognitive and behavioral difficulties. So we look at ascending behaviors for high mood and descending behaviors and thought processes for low mood. So we're looking to recognize subtle mood, cognitive, and behavioral changes to allow for early intervention, evaluate and change distorted and unhelpful thoughts and beliefs, such as suspiciousness, grandiosity, or worthlessness, and organizing and scheduling of activities so that you might limit or reduce overstimulating activities when going high and behavioral activation in line with values when depressed to be able to improve mood. So there are many different factors that can lead a vulnerability to a mood disturbance to becoming an episode. Just for time purposes, I'm going to move forward a little bit. So what we typically encourage people with bipolar or patients with bipolar to become experts on their own personal triggers and how these can be managed. Again, common factors to consider are seasonal change, sleep, work issues, relationship issues, pregnancy, grief and loss, drugs and alcohol, or prescribed medications, positive life events, which can be also stressful, east-west travel, shift work, conflict, anniversaries, holidays, social events. So just be mindful of what triggers could destabilize mood. And one of the things I really want to emphasize before we end is that there are support groups for patients living with bipolar and also support groups for friends and family members of patients living with bipolar. When we think about the impact on carers and supporters, anyone involved in the care of a family member with elevated mood is associated with increased levels of stress and distress for themselves. And carers might well require encouragement and permission to look after themselves, as well as being given information and support as to how to access further information, such as the AWARE organization. So I'm going to touch on that in one moment. Just to briefly follow up on what I mentioned earlier around expressed emotion, this is when we're referring to the general level of criticism, disapproval, and hostility expressed. So people recovering from bipolar affective disorder are considered more likely to relapse. Their families in particular rate high in expressed emotion. Low in expressed emotion involves reserved criticism, limited hostility and contempt, and greater acceptance and caring concern. So if a patient of yours with bipolar, when you explore it, their family system has a lot of hostility, blame, and criticism for them not getting better or being ill or the impacts of their illness for them, that would be leaving them much more likely to relapse or have a worse prognosis going forward. So family intervention would likely be helpful. And again, just to try to move from high expressed emotion towards low expressed emotion if possible. So in terms of support groups for adults living with bipolar affective disorder, face-to-face groups are occurring, but at the moment there are still more online groups as we move out of the pandemic. So there might be a mix of options between face-to-face and online support. All have potential benefits. So with AWARE, there is a group program called Living Well with Bipolar Disorder for a patient with bipolar. The Bipolar Education Program here in St. Patrick's University Hospital also has a number of treatments for those with bipolar. That does require that they would have health insurance, and where it does not. And then you also have a recovery organization that has group supports as well. When it comes to the caregiver or supporters of those with bipolar, Relatives and Friends program of the AWARE organization have a specific support group for those people who are supporting a loved one with bipolar. In a more generic way, family carers have carer support groups alongside for young carers. You have youngcarers.ie. And I've just listed 3 different sources. They're blogs, videos for families and friends of those with bipolar who have shared their experiences. And it might be helpful for those who want to maybe relate or find out more about other people's experiences in similar situations. So I think I probably won't have time to do this section basically, but this was going to be looking at different phases of I suppose treatment, between maintenance phase when things are going well, adjustment phase if they're becoming unwell or having hospitalized and post-discharge, and crisis phase if they're becoming specifically very unwell. So your role and how you support or intervene at these different points could be very important to what happens in terms of their prognosis or their outcome or their recovery. So when we think about recovery and resilience, education, treatment, and support, and the right type of each really can make a significant difference. So I might well just end there and go to more the Q&A section, given the time, if that's okay. If anybody has a question, that is.
I don't think we have any questions as yet. We'll give people a minute or two to put in any questions or queries they have. And in the meantime, I'll thank you on behalf of everyone joining, Sean, for that really informative and comprehensive presentation. You covered a huge wealth of information within the time. And just while we're waiting to see if any questions come up, just a reminder for people that CPD appointments from the ICGP are available to any GPs who have attended this evening's event, and they will be sent to you automatically over the coming 4 weeks. And a recording of the webinar will also be made available on our GP CPD portal, and I'll share the link to that in the chat now. And just to note also, when we sign off this evening's webinar, you'll see a link on your screen where you can share feedback, and we'd love to hear your thoughts to help us improve future events. So if you do have 2 minutes to spare, we'd ask you to do that. I think we have a question coming up there. Let me have a look. So we have a question from someone joining us who asks, do you use a contract with people to outline what treatments can be given when they're unwell, but when they perhaps won't realize they are unwell? So kind of going back to that concept of insight, perhaps, that you mentioned earlier. Thank you for that question.
Yes, absolutely. Thank you, Finola. So the answer is yes. So the intention is that when a person is well enough, that there is a shared agreement and understanding as to, at each stage of perhaps a lapse or relapse that occurs, what kind of care or support they would want and wouldn't want, who they might want involved, how they want to be communicated with, so that ideally their healthy self is able to guide the support network and the clinicians involved according to their wishes. And when that person becomes unwell, in particular if they're manic, that agreement is not really worth the paper it's written on, I suppose, if you know what I mean. So their perception of their behavior, their need for treatment will be very different, but at least the understanding is there. And there is, I suppose, that permission of friends and family to intervene or communicate their needs to a GP or a psychiatrist, or to be involved in their care. If that's already been agreed upon, that does help that to happen. So that with that permission from their well family or friend, that it's more likely that there'll be better collaboration and communication, and also clarity regarding how to proceed. So that's called an advanced directive. So that's something within the bipolar program. We have a 10-week group that we run called the FACTS, and it's something that we encourage people to do, particularly with a key supporter. So essentially, that's the person that they would like to be most involved or would be most closely trusted to support them while they're well, and if they become unwell in particular.
Absolutely. I think as well, people should be able to find information on advanced healthcare directives at the Decision Support Service website. So I'll share that in the chat as well. Thanks for that. If there's any other questions, you can ask them now. Pop them into the Q&A while we have Sean's expertise to hand. I don't think there's anything else coming up. And I'm sorry, I hope we didn't rush you too much, Sean. I was conscious, I didn't want to interrupt your flow, but I knew you had an awful lot to cover.
Oh, no, I'm glad you did. I appreciate your help. You can get a bit absorbed in what you're doing sometimes. So.
Absolutely. There doesn't seem to be any other questions from the audience. So with that, I'll thank you again, Sean, very, very much for your time and sharing your expertise and knowledge, and thank all of you for joining this evening. And I wish you all a lovely evening ahead. Bye-bye, everyone.
Thank you very much, and have a good evening. Thanks for having me. Bye now.